Okay, so make sure that you're going over the pharmacology module. Make sure that you're looking at those medications. So for BLS, we have those 8 medications that we're able to administer or assist with. So what I want to do is I want to kind of do a kind of quick demonstration and look at kind of how we tie this in and why we spend so much time going over this. Remember when we say that, medications, the most dangerous thing that we do as an intervention is going to be administering these medications. The reason that we're able to do this, in our standing orders as an EMT is because the medications that we're allowed to give are life-saving. With that being said, if we give them at the wrong time or for the wrong reason, they can also be life-ending. So, these are rescue medications that, will have a significant benefit for the patient, but we have to be able to do a good assessment to be able to figure out what's an appropriate treatment plan and how are we going to follow. How do we know which protocol to follow? We have to do an assessment. So again, that assessment is the most important skill that we have at any healthcare, provider level. Your best tool, if you can do a good assessment, you're now able to take care of any patient, right? So when you can do that assessment, you understand what the symptoms are telling you, you understand what your vital signs mean, and you're able to put that together. You're now start to, prioritize and take care of a patient no matter how sick or how injured they are, all right? So let's take a look at a patient who's having chest pain. So this is where we get to see what we do and kind of how cool our job really is. So we take a typical patient who's complaining of some chest pain. So we get a call for that. They're doubled over, they're feeling inside, they're clutching their chest, and we're starting to kind of put this together. So when we start looking at chest pain and we start to kind of question, all right, so if I'm looking at chest pain, where's the problem? Right? So and the heart, thank you, yes, well, okay, we'll start there. Specifically, we're looking at the coronary arteries. So the coronary arteries, remember, those are the arteries that are perfusing the heart, right? So we do a quick kind of look at our kind of vocab again, and we put this together. So when we look at this here, we're going to say that this is a segment of our coronary artery, right? Clearly not on the scale. Coronary arteries encompass the heart, and they're what allow for that oxygenation. So like we talked about when we were doing CPR, when we look at one of the reasons why we have to have good chest recoil, right? 2 reasons. Most people are able to get, during that recoil, that's where the ventricles, that's where they fill with blood, which is absolutely true. So when we look at that ventricular relaxation, right? When we look at our blood pressure, we have our systolic and our diastolic numbers. Relaxation is our diastolic numbers, right? During that period of diastole, this is where now the coronary arteries are getting their blood supply. So now they're getting their blood supply, they're able to perfuse the heart to get good oxygenation. When the heart is contracting, it flattens the coronary arteries. So a little bit of oxygen is able to kind of diffuse through there to be able to get to the myocardium, to the muscle, but not enough. During that period of relaxation, they open, and that's where the heart's getting its oxygen to be able to do its next contraction. When we think about it that way, it's like, well, geez, yeah, that kind of makes sense, right? So when we look at that recoil, if we are tired and we just lean on that chest, that heart muscle is going to just completely die because we're never going to be able to get good oxygenation to the myocardium. So you can do compressions all day long, but if you don't have that recoil, we've got a couple problems, right? We're not allowing the ventricles to refill, so we don't have enough blood to put into circulation. So now the rest of the body is starting to die, and we're not getting good oxygenation to the heart. So, the whole reason that we're doing this is trying to keep that blood circulating and have a steady supply of oxygen. So when we look at a heart attack, right? So CPR, we're looking at cardiac arrest. We know we've got an electrical problem. Heart's not beating. When we look at a heart attack, we have a plumbing problem, right? We have a blockage, an occlusion, something somewhere. So when we start to look at this, if we start to look at some of our risk factors, right? So you have somebody who's, kind of overweight and, by the time we're kind of mid-age, we've made some poor life decisions, right? More burgers and salads, maybe a few adult libations. So now we've, a sedentary lifestyle. So now all of a sudden we've done a bunch of things that have now contributed to some poor heart health, right? We've increased our risk factors. So one of the things that we looked at, and again, I'm terrible at drawing, and this is just kind of to help us kind of wrap our head around some of these concepts. So when we look at our coronary arteries in the body, our bodies have areas where they prefer to have cholesterol deposits, right? So some of the areas, coronary arteries, the carotid arteries, the femoral arteries. So arteries that are super important, this is where now the body has a preference to having some of this plaque formation, right? So when we talk specifically about our coronary arteries, if we were to look at this, and we look at kind of these plaque formations, we start to have this kind of, these deposits, right? These fatty lipid deposits. And so what happens is, you know, the way I kind of think about this is, you know, if you look at like bubble gum, right? So you chew up your bubble gum, and you put it on your plate while you finish eating dinner, so you can, you know, when you're a kid, you know, because you knew you only had one piece, you put it on your bubble gum, you put it on your bedpost the next night, and then you go and you look and you pick it up, you know, the next morning. It's hard, but you start to work it in your hand, it's still malleable, all right? So in the beginning, when we start to have these lipid deposits, they're still kind of malleable, and this is where now we start to see interventions like the balloon angiography. So now we're able to go in and they're able to kind of flatten that down to increase this internal diameter of the coronary artery and be able to restore this blood flow, okay? If you were to take that same gum, you put it on a chair, you come back a year later, now you can't just take it off, and now you're kind of, as you're scraping it off, it's breaking off in pieces, right? It's hard, it's chiseled, and that's kind of what happens when we have these deposits over time, they start to harden. When they start to harden, right? Now remember that our arteries, high pressure system, and the arteries have a muscular wall, right? So they have a muscular lumen that now it allows for the the constriction and dilation of the vasculature, right? So when we start to increase, our cholesterol, and we start to have this increased resistance, so we're narrowing the internal diameter for this blood flow, and now what happens is we start to see an increase in the resistance. So we now start to see an increase in BP as well. So a lot of times we see patients who have high cholesterol and high blood pressure, and a lot of times we'll see them on medications for both. So when we look at there being kind of this problem, it could be for any number of reasons. What we know is that there's some type of occlusion that's now interfering with our blood flow. So when we look at our definitions again, right? So we have ischemia. And now ischemia is lack of blood flow. All right? So if we're not able to get blood to travel where we want it to, what's happening now is all of those cells that are distal, so from the point of the blockage further away, now what we have is we have something called secondary hypoxia. So when we say that something is secondary, it's caused by something else. So if we have, an area that's ischemic, we have a lack of blood flow. If we can't get blood there, we know red blood cells carries oxygen. We now have secondary hypoxia. We can't get oxygen to them, those cells are going to start to become hypoxic because they need a constant supply of oxygen. All right? So hypoxia, lack of oxygen. Okay? So when we start to see this here, we start to see these deposits, we start to see this increase in blood pressure. And now what we start to see is either this could be caused by a blood clot. So when we look at a thrombus is a clot that forms and then stays where it's formed. So it's stationary. It kind of develops and stays. And then we have an emboli. And an emboli is going to be a clot that travels. So we've talked a lot about, if it travels to the heart, it's a heart attack. If it travels to the brain, it's a stroke. If it travels to the lungs, it's a pulmonary embolism, okay? Because those are our vital organs, when we have these, emboli, this is where now these can be life-threatening. So this could be caused by a blood clot. It could be formed by a piece of plaque that's broken away, now has kind of lodged, in this narrowing, internal diameter. It could be caused when we look at, stimulants, so like a cocaine overdose. Now that can cause a vasospasm. So now that muscular wall spasms, they can close shut, and now that can cause this ischemia. So when we start to look at ischemia, in our mind, we start to think injury. All right? So if something is injured, we can fix it. So now we're going to have interventions we can do to start to fix this ischemia. When we talk about death and we look at infarct, death, you can't come back from that. That's bad juju, right? So once this myocardium, once the muscle dies, it's dead, all right? What happens is now, if we look at a heart, and again, I know this isn't anatomical, and we look at these, our blood vessels, what we're looking at is, if I have a clot that's here, this part of the heart muscle is now deprived of oxygen and can die. I have a blood clot here, this part of the heart muscle is deprived of oxygen and can die. So now this is also, we're looking at, it's dependent upon where this clot is. So certainly, this is where now we want to make sure that we're getting ALS involved, where we're able to try to get them on a monitor, we're able to see kind of more definitively what's happening, all right? At our BLS level, this is where now we come in, somebody's complaining of chest pain, so we start to look at how this happens. So we'll say that we have some, big old clot here, and now all we have is this little area for blood to flow. So blood's coming through the body, and all of a sudden it gets to here, and it has to kind of slow down. Right? So now the blood over here starts to, back up, and it starts to stop moving. When blood becomes stagnant, it starts to clot, it starts to congeal. So I always think of, clots in the body as like mice or ants. You never have just one, right? You may see one, but others are now, running amok. Same thing here when we look at these blood clots. So now, even though this is where, potentially, this could be a blood clot, it could be any of the other reasons we talked about. For example, right now, if we're looking at a blood clot, we know that we have at least one, and now we know if we don't do something, we're gonna have a bunch more form here. As this blood starts to back up throughout the rest of the body, because that's what's gonna happen, is all of a sudden this is gonna start to cause this backflow and this congestion. Now what happens is we have clots developing in the liver, in the kidneys, and now we start to have, our organ failure. So we come in and we look at what we're able to do for this patient. So we come in and we determine that this patient's having chest pain, is cardiac in nature, and we want to come in and try to fix it, right? So we know that if we've got a blockage here, what happens is when we look at our metabolism, right? So when we look at metabolism, all of these definitions coming back to haunt us, right? This is work of the cell. Every single cell has a job to do. Every cell requires a constant supply of oxygen, of glucose, and of water. So when we look at this metabolism, we have our aerobic and anaerobic. So aerobic means with oxygen, and anaerobic means without oxygen, okay? So when we look at our perfusion, another important definition, right? We have a whole chapter where we talk about shock, our hypoperfusion. Perfusion is the delivery of oxygen and nutrients. So for our purposes, we're concerned about glucose and water, all right? And the removal of waste products, right? The byproducts of our metabolism. For our aerobic metabolism, our byproducts are carbon dioxide, a little bit of heat, a little bit of water. Anaerobic metabolism, lactic acid, a little bit of heat, a little bit of water. Okay? So, the heart, important, vital organ, it has to keep beating. So, if all of a sudden we have an occlusion that now is causing everything from here this way to become ischemic, all of the cells this way are starting to have that secondary hypoxia. So they're now starting to try to do work, but they're being deprived of oxygen. They're going to switch to this anaerobic metabolism. So now this byproduct is this lactic acid. So now they start to kind of feel this chest pain, right? We are really bad at being able to describe pain. So if I were to go and kick you in the shin and be like, now, how does that feel? The way that we describe pain is not great. We're not very good at being descriptive. You know, it hurts. It's like, well, can you describe it? I don't know, it just hurts. So we see that patients a lot of time have a hard time with this. We start to see now people complaining of chest pressure, heartburn, nausea. We can start to have a lot of different symptoms that are because of what's happening here. So, you know, when we have somebody who's now complaining of chest pain, we now know that they have some type of occlusion or narrowing that's now been going on long enough to cause them to become ischemic, have the secondary hypoxia, switch from aerobic to anaerobic metabolism, and is now starting to have these byproducts that's causing them discomfort. Pain is a signal in the body that something's wrong, right? So we come in and we start to look at our interventions. So now we offer them aspirin, right? So aspirin, we give them 324 milligrams for baby aspirin, or one adult 325 milligram aspirin, depending what you carry. And we give them that adult dose. We have them chew it up, lots of vasculature in the mouth, and aspirin is an antiplatelet medication. So now what it does is it prevents this clot from getting any bigger. For example here, saying this is a clot, it's going to prevent new clots from forming. So aspirin, when we look at those test cards, is the most important drug that we give. Right? Because we now know that we're stopping other clots from developing in the body that we know if they go other places are also going to wreak havoc. All right? Now, if they have a prescription for it, what we'll do is we will assist them with their nitroglycerin. Okay? So their nitroglycerin, right? So we look at our aspirin, as long as they don't have those contraindications, right? They're not allergic to it, and they don't have any active bleeds. So not just a GI bleed, but no bleeds. Nitroglycerin, we're making sure that their blood pressure tolerates. So for testing, they're looking at 100 systolic. Most places, you know, Massachusetts, if this is, you know, where you're looking at, ours is, you know, 120 systolic. So we know that when we give nitroglycerin, it's a vasodilator. We're going to cause that blood pressure to drop. So if we're already starting with a low blood pressure, we could drop into something that's just too dangerous, right? We're not going to be able to have the patient rebound. So this is where now we have to get vital signs before we give nitroglycerin. We have to make sure that we have a systolic blood pressure that's going to tolerate this drug. The other thing is we need to make sure that they haven't taken any class of drug that are phosphodiesterase inhibitors type 5. And this is where we're looking at those, you know, kind of classic, what we know as erectile dysfunction drugs. Now, people can take these for lots of different reasons, all right, especially in different doses. So we want to ask males and females if they've taken these medications. You should not ask a female patient if they take erectile dysfunction medication. They're going to question where you took anatomy. So people can take them for, you know, the reason that they were originally, you know, kind of created was for pulmonary hypertension. So there's different reasons that patients take them. Women can also take them for sexual enhancement. So we want to make sure that we're asking this in an appropriate manner. Do you take any medications in the last 3 days? We're looking at the 72-hour window. Anything outside of that, we don't care about, but you need to ask the patient, okay? So once we've determined that there's no contraindications and they have a prescription, so this is where now they have to have this. We don't carry it on a BLS ambulance. We would have to assist them with their own medication, all right? So if they have this and they have the sublingual tabs, 0.4 milligrams. Sublingual means it goes under the tongue. If they have the spray, we do one spray, which is about 400 micrograms, and that's a lingual spray, it goes on the tongue. So this is dependent upon what the patient has, all right? Make sure it's within expiration. We've ruled out our contraindications. Now what we do is we give them this, and this is a vasodilator. So now what we see happen is we start to see this dilation of this vessel. So we still have, you know, the cholesterol that we had before, and now what we see is we've opened up more space for blood to start to pass through here. So it's kind of like if you think about like a car accident, right? So all of a sudden, you know, it's a 4-lane, you get an accident, everything goes down to 1 lane, and everything kind of essentially comes to a crawl, and in some cases, a complete stop, right? Now they start opening up a 2nd lane, you're moving. It's not like it is when it's 4 lanes and you're able to just kind of move freely, but you're at least not in park. So that's kind of what this is doing. We're able to give this nitro lasts for a short period, but it increases, it causes this vasodilation. So now it's making it a little bit bigger. So if we do have this impasse, we're able to try to get this blood, right, reverse this ischemia to be able to get this blood flow. Once we do that, now we can get oxygen back to these cells, and now we can start to look. So maybe you come in, you've got a patient complaining of chest pain, you recognize this, you follow through with our appropriate interventions, and now all of a sudden they get to the hospital and they put them on the monitor and they do lab draws, to check for their troponin levels, and they come back and say, wow, you were very lucky. You didn't have a heart attack, but this is kind of, that big warning sign to you. Nobody ever gets the pat on the back because you came in and prevented, the heart attack, but you know what you did, right? This is why when people say, what do you do for a living? You go, I restore perfusion, and you flip your cape and you walk out, right? This is amazing. This is what we get to do. Every day when we go to work, we get to interact with patients where we have a direct result on the outcome of that patient. This patient being able to return home to their family. Maybe they did have a heart attack, but they didn't die. Now they're able to, after some rehab and some counseling with, some lifestyle changes, they're now able to return back to their family. They're able to watch their kids grow up and see their grandkids or be there for the weddings and the birthdays, right? They don't miss those things. And you don't have the extended family now who's, dealing with, grieving the loss of the husband, the father, the son, the sister, the mother, the brother, right? Now we're looking at being able to return people whole back to their families. That's what we do. That is amazing. You have to understand how the body works. The reason we spend so much time on anatomy, on physiology, on the mechanisms of the drugs, where we beat this into you, is because it matters. One day, when you finish this course, you're going to be standing in somebody's, living room, and you're going to be looking at a patient, and it's going to be, the only thing that's going to separate them from, life and death is going to be the decisions and the interventions that you do. You have to recognize that this is different. When we look at, really a 75, 68 is really passing. 75, we kind of put in, you can only kill, 1 out of 4 people. And we kind of joke about it, but this is where now, what information isn't important for you to know? Do I really need to know all this? Yeah, because you don't know at what time you're going to get the call for the patient that has the condition, and they're relying on you to be able to recognize what's going on and pick the correct treatment to stabilize this patient and get them to the hospital alive. So we have a really awesome job, but with that comes an awesome responsibility. So we have to make sure that we understand this. We have to recognize that if we're going to give a medication, we know why we're doing it, there's no contraindications, and that we understand what we're supposed to see. If I don't know how this medication works, how do I know? If I don't know what the effects are, how do I know if it worked for my patient, right? So this is kind of just one example, and we kind of bring this in, but this is exactly what we're looking at. So every time you go out and you interact with the patient, you have to figure out, based on your assessment, what's going on, and then based on our protocols, what interventions are we doing for this patient? What's appropriate? And what's going to make sure that we stabilize this patient, get them to the hospital, and not cause them any harm, right? All right. We'll see this again.